So I might start, if that's all right. I think maybe my watch is fast, and that seems to be a bit slow to me. So you're all very welcome. My name is Michelle Leach, and I'm Associate Professor and Head of the Discipline of Radiation Therapy here in the School of Medicine. So it's great to see so many of you here who are interested in our course and in our profession. So what I'm going to do for maybe the next 15 to 20 minutes is just tell you a little bit about the profession of radiation therapy, because sometimes people get a little bit confused between radiation therapy and diagnostic radiography. And then I'll go into some detail about our course, and then we'll have time at the end for whatever questions you might want to ask. Now, make sure I do it right. Oops. Let's go back one. So I suppose just to clarify a couple of things. If some of you have been looking at courses like this in, say, in British universities, sometimes it's called therapeutic radiography in the UK. But we have adapted the European title of radiation therapist. So that was changed probably about 5-6 years ago. So the title of our course has changed accordingly as well. Okay. So when I was an undergraduate, my degree would have been a BSc in therapeutic radiography, but now our students will graduate with BSc in radiation therapy. So it's the same degree as therapeutic radiography. It just has to do with the title of the profession. So the European adapted title is radiation therapist, but in the UK the term therapeutic radiographer is still used. So I suppose what's the relationship to what we would call diagnostic imaging or diagnostic or general radiography? There's really none, I suppose, is the main thing. We are part of the same professional body, so all healthcare professions and most professions in general obviously have a professional organisation that looks after fitness to practice and standards and so on and so forth. There's seats down the front if you want to come down. But I suppose that's probably where it begins and ends. We're part of the same professional body for historical reasons. Sorry, do you mind maybe moving in a little bit and then the people can come in at the end? Sorry. Not at all, you're fine, there's no problem. It's not the easiest room to kind of sneak in and out of, unfortunately. So, a little reshuffling is no harm. So just wait till everyone is more or less settled and we can take it up again. It's bad enough having to get out of bed on a Saturday morning without having to stand while you're listening to me as well as everything else. So we are part of the same professional body, but as I said, that's really for historical reasons, because the profession of radiation therapy is quite small, okay, worldwide, relative to diagnostic radiography. So when we started our professional body, or it was started quite a number of years ago now, I suppose radiation therapists didn't have that critical mass of people to form their own professional society. So therefore we joined forces with our colleagues in diagnostic imaging. And we're still, even though we now have that critical mass, we're still part of the same professional body, because actually we work really, really well together. We have a scientific council, and we work quite well together. And I suppose we have some of the same goals in terms of where our professions are going. The main differences between diagnostic radiography or diagnostic imaging and radiotherapy is that our patient populations are very different. So we will nearly exclusively only see cancer patients. There are some very, I suppose, few exceptions to that rule, but in general, probably 97, 98% of our workload is associated with cancer patients. So that's obviously the main difference. And also the type and quantity of radiation that we're using is very different as well. So you'll learn about that in the physics component of the course. So in diagnostic imaging, we use much lower doses of radiation. So be it in CT or in just taking a plain X-ray of your arm if you broke it, or your leg or whatever, versus to the types of radiation that we deal with are in what we call mega voltage energies, which are about 1,000 times as strong as what you would use when taking an X-ray. So obviously then that tells you that it's a profession where you have to be extremely careful and extremely skilled when you're dealing with radiation of that magnitude. So that summarises it then, that radiotherapy and radiation therapy are terms that are used interchangeably. And you'll even see that as I'm speaking, sometimes I say radiation therapy and sometimes I say radiotherapy. Sometimes you'll hear patients referring that they're having radium treatment, and that's a very old term because radium is a radioactive source and it's really not used anymore for safety reasons. Very, very rare to see that now. So radiotherapy then is a specialised branch of medicine that's concerned with the treatment of malignant disease. And malignant disease basically means cancer. So we use very high energies, and they are potentially lethal doses of radiation if they're not administered correctly. Okay, so we have to treat to these really high doses in order to achieve potentially cure and certainly tumour control in the patient. But I suppose what's really important, and if you've gone to other healthcare professional talks this morning, you'll know, is that malignant tumours or cancers are not just cancers, they obviously reside inside a person. So as well as being very technically minded and very accurate, you also have to have quite good people skills to be a radiation therapist. Because this, and I'm sure some of you have probably had personal experiences maybe within your family or friends of cancer, and you know what a devastating time it is for patients. So being able to take care of the patient as a whole is really fundamental in radiation therapy. So we don't work in isolation. Very few health professionals do these days. So we work as part of a team which also includes oncologists, so both medical oncologists who are oncologists who deal with chemotherapy and radiation oncologists who obviously deal with radiation and surgical oncologists. So we're part of a very skilled team. And we also work very closely with physicists, in particular medical physicists, to plan and deliver radiotherapy doses and regimes. On the people skills side, I guess the radiation therapist is the main point of contact for a patient throughout the course of treatment. So, you know, we could see patients for quite a number of weeks. So, for example, if we were treating someone for prostate cancer, we may see that person for 7 to 8 weeks every day, 5 days a week. Sometimes we have, you know, reduced numbers of treatments depending on what you're treating. Sometimes if you're treating someone who is a palliative patient, and so your aim is not to cure them but to alleviate their symptoms, you may only see them for a week, but that can be a very, very important week in that person's lives. So we are the main point of contact. So therefore, the accuracy and precision of the treatment is our focus, but also looking after the patient on a human level is very important as well. So these are just some images of, like people usually say, it's like the man in the iron mask when I put these things up, of some of the types of work that we are involved in. And if you have visited our stand in Luce Hall, you'll see we have some of these masks over there for you to have a look at. So this is, actually this was a student, it obviously wasn't a patient, but so this is called a thermoplastic mask, and it's really important in radiotherapy that the patient is as still as possible. So if you're treating someone who has a tumour, say in their head or neck region, so that could be maybe a tumour of their voice box or their larynx, or the upper part of their food pipe or esophagus, or maybe something in their sinuses. It can be a number of different things, a mouth tumour. We can't rely on the patient to stay still. It's just impossible. Nobody could do that. So the patient has to be fixed or immobilised in some way. So it takes, I suppose, quite a lot of skill to prepare one of these thermoplastic masks. So basically it starts off as a flat sheet of plastic and is heated in a water bath to 65 degrees. And then it's placed over the patient's face and shoulders. So the radiation therapists there are moulding it to the shape of the patient. So it means then that obviously every mask is individualised for each patient, so that we can be sure that we're treating the patient as accurately as possible. And we have to treat to within millimetres accuracy. So it's quite vital that the patient is fixed or mobilised correctly.
Yeah, you can tell me in the back. On the stairs.
We're getting given out to. So that would be the first aspect of, say, pre-treatment, and that's one type of mask. And I think I have another one coming up that looks probably a little bit more scary. And this, I suppose we'll go to the end product of it first, is the one on the left. So that's a Perspex mask, or a beam directional shell, it's called. And to make that then, we basically take an impression of the patient's face using their plaster of Paris bandages. So maybe if you've had a broken arm or foot before, you know what I'm talking about. So they're placed over the patient, keeping their airway, so their nostrils and their mouth clear, and left to harden just for a few minutes. And then the next, this impression then is basically filled with plaster, liquid plaster. Sorry, can you take your argument outside? Thanks. So that's then filled with liquid plaster and left to harden. And then finally, in the final step, a sheet of plastic is placed on basically like a heating rod, and it's made. So there's some, I suppose, aspects of work that maybe you hadn't thought about and can be quite practical. So they suit some people as well. So we work in all areas, so then you end up being skilled in all areas. So I suppose one of the main points, another point of having a mask like this is so that we have to have some guidance marks on the patient to direct us to where the radiation is actually going to. Okay, and we use lasers in the treatment room for that. So if you're treating someone obviously in the head and neck region, you can't mark someone's face obviously. So therefore all the marks can go on their mask. So the purpose of the mask is twofold then, to fix or immobilize the patient, and also to give the radiation therapist guidance on where they're actually delivering their treatment to. And then the next aspect of care and the next area that we work in is a place called treatment planning. Excuse me, and this is a very important area because this is where we calculate all the doses to the patient. Okay, so this is just a CT image, an axial slice, so like a cut down like this through male pelvis. So this patient is being treated for prostate cancer, and so what we have outlined, if I got a pointer, not sure it's working, is it? Oh yeah, this one is. So what we have outlined here in red, so the red thing here basically is the patient's prostate, just on one slice. Obviously it's in 3 dimensions because it's in a patient. So that's the man's prostate and seminal vesicles here, and this is the rectum, and the yellow one above is the bladder, and these blue things here are the heads of the hip bones, or the femoral heads. And what the lines around tell us is this patient is being treated with 1 beam coming down from the front and 2 beams coming from the side. And what the other lines here are showing us is what dose the prostate is receiving, and what dose the rest of the patient is receiving too. And that's critical, because what we are trying to do obviously is get the really high dose to where we want to treat, to the prostate, but you know, obviously the beams are still going to come through areas that we don't want to treat, and we try and minimize the dose to those structures. And if we don't minimize the dose to those structures, then your patient can end up with unacceptable side effects. And that's not, you know, we can't have that. So, so while there will be some side effects, they have to be kept as low as possible. So that's why you need to have a good understanding of this process called radiotherapy treatment planning, which I suppose brings in a little bit of physics knowledge into it as well as clinical experience, and work out what is the best dose for each patient. So that would be, say, the next area that you would work in radiotherapy. And then the final area, of course, is the treatment unit. So maybe some of you have been to some radiotherapy departments before. So this machine is called a linear accelerator, and you can see the patient lies on quite a narrow couch, and it's not because we're very mean and we don't want to give the patient something comfortable to lie on. It's because this part of the linear accelerator here, the head, which is called the gantry, can rotate around the patient at any angle, 360 degrees. And of course it has to be able to do that because we use these machines to treat cancer of any part of the body. So we have to be able to rotate it. And particularly if you think about that we're trying to avoid treating certain tissues, well then we might have to bring our beams in at kind of unusual angles or oblique angles from different sides. So that's why the couch is very narrow. And all of these treatment units, linear accelerators, you can't really see it clearly here, but they're also fitted with very sophisticated imaging equipment, okay? Because obviously it's important that we're always constantly checking that the patient is in the correct position. So once we decide on that this is the patient, or this is the position, and this is how our treatment plan should look for this patient, and you might remember I said at the start, we might treat a prostate patient for 7 or 8 weeks. well, that has to be identical for 7 or 8 weeks, or otherwise we're, would lose the probability of curing the patient. So that's why advanced imaging is very important in radiotherapy. So what kind of person do you need to be a radiation therapist? So I hope I've shown that you do need to have quite a range of skills, and we like to say you have to be a bit of a perfectionist. And obviously the reason you have to be a bit of a perfectionist is that, good enough is not good enough. It has to be exact in radiation therapy, You're dealing with people who are in a very vulnerable position and who are depending on you for quite a lot, and probably in most cases are putting their lives and their well-being in your hands. So you have to take that responsibility on board. So you do have to be a little bit of a perfectionist. You have to have a high degree of technical knowledge, that obviously you learn during the course, and precision, accuracy and attention to detail is paramount. But of course, I suppose there's two sides to that. You also need to have excellent people skills, because if you have people coming to you who are in a very, very bad situation in their lives, which most obviously cancer patients are, it's a very serious time for them, you have to be able to deal with that as well. So it's a little bit of a mishmash of two things. So if we look at what the course actually contains then, so of course the course is designed so that you achieve this at the end of the course, that you have the people skills and that you also have the technical knowledge and that you understand how important accuracy is. So because it's an honours science degree, the first years cover what we would term the basic sciences. So in first year we cover physics, chemistry, biology, anatomy of the thorax or the chest, the pelvis and the limbs, and that's anatomy, so cadaver anatomy, and also cadaver anatomy means dissecting bodies of people who have left their bodies to science, and also radiographic anatomy. So that's important, that you can identify structures on the images like I showed on the CT. Then the first year sees the start of quite an important module called Principles and Practice of Cancer Care. So in that we start looking at maybe the causes of cancer, the epidemiology of cancer and things like that. And Psychology and Communication 1 starts immediately in first year, because we understand how difficult it is, particularly if most of you are coming from school, to suddenly find yourself in a hospital environment caring for patients. It can be a little bit daunting, so we start that straight away. So in second year then, the anatomy proceeds up to head and neck anatomy and neuroanatomy, so anatomy of the brain and the spine. And you also take course modules in physiology and biochemistry, and then we continue with psychology and communication too. And then your physics becomes quite specific from second year. Okay, so the first year physics course is quite broad. It has some radiation physics, but it's quite a broad physics course so that you understand the concept of errors, which obviously is important in radiotherapy. But in second year we focus straight in on radiation physics. We carry on with Principles and Practice of Cancer Care, and research methodology and statistics is a very important part of this course because all health professionals at the end of an honours degree should really be in a position to undertake research in their own field. So what you learn at undergraduate level, in a field such as radiation therapy where technology is constantly changing, that will change maybe 10 years after you've graduated, 5 to 10 years. So of course it's the role of health professionals to make sure that they are treating patients based on the best possible evidence and not on what they learned 10 years ago. So we make sure that our students are well equipped to undertake research in the field upon graduation. And we have lots of radiation therapists who are just involved in research. So the final 2 years, third and fourth years, or the sophistry years as we call them here in Trinity, they consist of an in-depth study of cancer and its overall management. So at that stage you would really be learning everything about everything to do with breast cancer, prostate, all the main cancers, and some obviously of the unusual ones that you will come upon in your career as well. The professional skills of radiotherapy. Your own self-development is very important because this is a difficult career and it isn't for everyone. So it is important that you know how to manage, I suppose, yourself and also see where your career is going to. And healthcare management, is important as well, because as you progress up through your career, you will be managing units and eventually departments as well. And the 4th year then culminates in quite a substantial research project in the field of radiation therapy. So for clinical placement then, clinical placement starts in 1st year, but I suppose the bulk of our clinical placements take place kind of in the last 2 years. I suppose there's no easy way in any of the healthcare professions. Quite a substantial amount of placement does take place during vacations or holiday time, and in total we have about 40 weeks clinical placement over the 4 years. And our students are placed in centres all around the country. So there are radiotherapy departments in Galway, both public and private, in Cork, in Waterford, there's one in Limerick that's associated with the Mater Private, and then the rest are all Dublin based. Okay, so everyone is placed for a certain period of time outside of Dublin, and I suppose it's important for the parents in the audience to know that that is at the student's own cost. So it's good to tell you that straight up, I think. So in the freshman years, there are just short introductory placements. So in 1st year, we don't expect you to, know everything about radiotherapy, obviously. But what we do expect you to do is to learn how to integrate yourself into a hospital setting. Okay, I think I said that already. So our assessment, we use quite a large range of assessment methods, again, which can be a little bit difficult if you've come from Leaving Cert, where everything is very focused on the end exam and that's it. You have to complete, you have to pass basically all modules in both the theoretical and clinical years in order to rise. That means to basically go up to the next year with your class. So we use quite a lot of continuous assessment. So of course we're very happy to see that the junior cert has been overhauled to include continuous assessment, because that's one of the major ways of assessing at 3rd level. We use project work both on your own and in groups, because as you have seen earlier, we don't work in isolation on our own, and getting used to working in teams is very, very important in any healthcare. And that again can be a little bit difficult for Leaving Cert students, where they have been focused on getting very high points on their own. But with practice, we all get there in the end. And then obviously you're assessed practically on your technical skills in the clinic. So in the final year, you have quite a substantial clinical portfolio built up, and then your research project or your thesis, they account for about 50% of the total grade in final year. So you're culminating towards this all the time. So, and now for yourselves, and obviously this is very important for your families as well at the moment, about career opportunities. So I think we're probably one of the few professions where there always seems to be posts that can't be filled. So radiation therapy is set to expand. So we have some new centres opened at the moment. So you may have heard in the news about the centre, the St Luke's Radiation Oncology Network is now in St Luke's in Rathgar, obviously where it has always been. But there's also 2 centres, one in Beaumont and one in St James's. And those 2 centres have been given the go-ahead to expand to their 2nd phase. So that means the number of units there will increase quite dramatically. So we anticipate there's good prospects for our future graduates, and I have some stats coming up for the parents in the audience now about where our graduates have gone. And should graduates wish to travel, really this qualification I have there is recognised almost worldwide, but really it's probably one of the highest, or it is the highest qualification in radiation therapy, probably worldwide. So our graduates, if they choose to travel, are always snapped up, certainly. The only exception there is in just because of the legislative requirements in America, because obviously they're governed from state to state. That's slightly different. That you do have to sit another exam if you want to work in the US, but everywhere else there is no problem. With our students, most work in the field. You'll see with the percentages. And it's not unusual, in fact, this is commonplace, that many of our students on their last long placement before they graduate are usually actually offered jobs before they've even graduated. So I think that's probably a little bit unusual these days. So of the class that graduated last year, 3/4 are working as RTs in Ireland, or radiation therapists in Ireland. 12.5% are employed in another field in health, actually in a research capacity that girl is working in. 6.25 are in further education. So they will be people maybe who wanted to go back and do something else. So maybe they're on taking a master's. Some of our graduates will go back and finish medicine. And then the remainder are working as RTs abroad. So I mean, we still have nearly 82% working in the field, and everybody is doing something. So that's quite positive. And then just of the other, I suppose I just gave you the figures for the last 3 years. In 2011, again, 76 are RTs in Ireland, so that's quite high then. So that's what, 92% are working as radiation therapists. And the people who are working abroad, they tend to choose to work abroad. It's not that they were forced to go abroad. They tend to just choose to go abroad. 4% are in further education, and 4 are abroad employed in another field. And of the 2010, it was slightly lower that year, and I know quite a lot of them that year, but when I say a lot, about 20% had to go abroad initially, and then probably within 6 months they were all back because they wanted to come back working in Ireland, so that was quite good. 17% are in further education, and 5 are employed abroad in another field. So that's it. So that's just an overview of radiation therapy and what it's about and what the course is about. So I'm happy to take any questions you have now. Don't be shy.
What level of income can you expect as a...
Sorry, excuse me, I have a bad cold. I think the starting salary, most of the healthcare professions are fairly similar. It's in and about 40,000, I think, and the manager salary, which clinically I suppose is the highest level you can get to, is about 70,000. Yeah. Anything else?
Is it acceptable to join with having done physics?
Yes. Yeah. Yeah. So the only requirement that we have is that you have at least an honours C3, which makes me laugh because of course anyone who gets the points would have much higher than that in physics, biology or chemistry. So we would have lots of students who would never have taken, who might only have one of those or might have 2. So for example, personally when I was an undergraduate I wouldn't have taken physics, but there is no issue because it's taught as if basically from baseline, as if you don't know it. And people are brought up to speed quite quickly. Now there is a steep learning curve. I suppose there's not the same amount of hand-holding that you have in school, but you are brought up to speed quite quickly. And certainly in chemistry, sometimes first years find chemistry quite difficult if they haven't taken it, but our chemistry department are really excellent and put on additional tutorials for those students so that they're up to the right standard.
So graduation rate, what's graduation rate from the class?
It would be quite high. We would have some people who would, I suppose if we lose people, sometimes we lose people in first year, and the reason that we lose them is that, or going into second year, is because maybe they wanted to do medicine and they didn't get it on HPAT. And so they can go back and have another go, and therefore when they go back and have another go, then they leave. We would have a certain amount of fails, but I would say we're probably about 85% graduation. Yeah. Yeah. Anything else? So if you go over to, if you've been to, sorry, go ahead. Yes. Oh yeah. Yeah. That's why, as well as that, I suppose you're qualified to go straight into work. But as well as that, most of our graduates would actually nearly be offered jobs before they'd even start. So it wouldn't be uncommon for people to, get their final results on Friday and start work on Monday. That happens quite a lot. And obviously, if it doesn't happen, it's because the students choose that it doesn't happen and they want to have a break, a well-deserved break at that stage. But you may have heard, if you have been at other talks, that a lot of health and social care professions now are going to be state registered for the first time. So radiation therapists will be state registered from next February. So basically what it means is that once you have this degree, you have to apply to the registration board for your licence to practice. But this is the degree that all others are benchmarked against. So once you have this, it's quite straightforward. Simply, if we've said that you've graduated with this degree, then you're just signed off to register. So you get the licence to practice that way. Yeah. Yeah, it just goes through the same process that any of the CEO goes through. So last year, our points were crazy last year because I think the honours maths pushed us up the same as everybody else, about 20 points. So I think we were in and about 540 or 545 or something last year. We're usually about 520, 530. So it is random selection. So even though, I mean, I don't know if we really go to a second or third round very often. Yeah, we only accept about 30. We only accept 30 basically students, just because of the numbers of clinical placements that we have in the country. So, you know, relative to diagnostic radiography, where there's a diagnostic imaging department in every hospital in the country, we can't take as many students because we don't have the clinical placements. So we'd love to take 80, but we can't, unfortunately. So we're hampered that way. So I suppose because we have quite small numbers, then the job opportunities are very good, you know.
Can you see the points for
I don't know. I don't know is the answer. It depends on what the demand is, you know. So, and I think the demand is probably quite high because it is, you know, maybe unlike some of the other healthcare professions, it is one where there are always job opportunities. So, and I know that probably the parents in the audience think, oh, you know, this is wonderful, and you'll all be convinced to try and get this course when you leave. But it is really important that I suppose you choose the course for the right reasons. And, you know, for some people it is very difficult working with cancer patients, and they can't see themselves in that role at all. And you really do have to be, a bit of a people person, but also be very technically highly skilled as well. So the points, I don't know, to be honest. I mean, I can't, at this stage, I don't know how much higher they're going to get. I know our colleagues in dentistry, I mean, you practically have to have a perfect leaving cert to get into dentistry now, which is, I know, it's quite difficult for anyone to achieve. Any other questions? Not like, you mean like if you didn't get the points and you started in another course, could you transfer? You can't usually do that. Usually on the transfer system, you have to have the points of the course you were trying to transfer into. So because if we didn't have that kind of regulation, then, you know, you could have, say, loads of people in science who really wanted to do medicine or do this, just trying to transfer across. What we do have sometimes are graduates from people who have undergraduate degrees in another discipline. They can be entered on a separate, not through the CO, kind of separately, as mature students. And sometimes people would have exemptions if they had, from certain subjects, if they had done a course that was kind of similar. But there's not really a way of doing that, no. Unfortunately not. Okay, so thanks very much for coming and enjoy your day. So sorry, I forgot to say, we have anyone who is interested, we do take tours of students, not today obviously, but on certain days throughout the year around the radiotherapy department. So if you go, our stand is in Luce Hall, which is the old sports hall. Maybe you've been there already. You come out this building and keep to your right, and we're taking a list of people who are interested, and we can contact you and let you know when that day is. So if you want to go over to the stand, to my colleagues, they'll take your name.